Welcome to this Older Americans Technical Assistance Center webinar on depression, anxiety, suicide prevention in older adults. I'm Jennifer Solomon, and I'm SAMHSA's Contracting Officer Technical Representative for SAMHSA's Older Americans Technical Assistance Center. I'd like to thank you for participating today. This supports a partnership between SAMHSA and the Administration on Aging to provide technical assistance to state and organizations as they implement behavioral health programs and services for older adults. Shows focus on suicide, prescription drug abuse, alcohol abuse, anxiety, and depression. This initiative is focused on persons aged 60 and older as for experiencing behavioral health problems. This initiative also provides technical assistance to 5 recipients of SAMHSA's grants to enhance older adult behavioral health, otherwise known as the Behavioral Health Program, as well as the Aging Services Network, to implement and enhance provision of behavioral health programs and services. The center also is going to provide 10 webinars. We are in the third webinar of 10 and 15 issue briefs, 5 Policy Academy meetings, which will be serving all 10 HHS regions. We also have another set of webinars that's part of the 10 that serve SAMHSA's behavioral health grantees. So we're focusing on alcohol and medication misuse and abuse, as well as suicide prevention, and the behavioral health grantees are also hearing the same information. I would like to introduce Marian Steinholtz from SAMHSA, who is the project officer on the behavioral health grant.
It doesn't appear to audio at this point.
Okay. Why don't I just go on? The purpose of these grants is to provide funding and focus technical assistance to a select group of grantees. These grantees are collaborating with the aging services providers, area agencies on aging and disability research centers, and senior centers. The partnership represents a change in the CMHS grant program, which previously had focused primarily on mental health service providers. In addition, the goal of the grant program are to address 2 significant public health problems noted to affect the quality of older adults and to prevent and address prescription and alcohol misuse, abuse, and suicide prevention. As I mentioned prior, there are currently 5 behavioral health grantees that include Jewish Family Services of Los Angeles, the Mental Health Association of South Central Kansas, Montrose Counseling Center in Texas, Jefferson Center for Mental Health in Colorado, and Oakland Family Services in Michigan. These follow the Targeted Capacity Expansion Program, which had 3 cohorts of grantees for each 3 years from 2002 to 2011. Overall, the 30 grantees addressed diverse mental health needs of older adults and in general made significant impact on decreasing symptoms of depression, anxiety, trauma, and other mental disorders while improving the functional abilities and the quality of life for older adults. I would like to now introduce Shannon Skowronski from Ministration on Aging, who is a partner on this initiative, and will further discuss how AOA and SAMHSA are working together to improve behavioral health services for older adults.
Thanks, Jennifer. As Jennifer mentioned, my name is Shannon Skowronski. I am the lead person for behavioral health at the Administration on Aging. And I'd like to, on behalf of Administrator Kathy Greenlee, welcome you to this webinar. We're thrilled to be partnering with SAMHSA on this important initiative and looking forward to providing technical assistance opportunities and tools for doing that work over the coming months. Some of you may be aware, AOA recently became a part of a new agency within the Department of Health and Human Services called the Administration for Community Living, or ACL. The goal of ACL is to increase access to community supports and participation while focusing attention and resources on the unique needs of older Americans and other persons with disabilities. ACL will support policies and programs focused on the unique needs of individual groups, including older adults with or at risk of behavioral health issues The vision for the AOA collaboration very much aligns with the goals of the ACL. So this webinar series really is intended to provide opportunity to learn about critical behavioral health conditions and problems affecting older adults, including depression, anxiety, suicide, and prescription drug use and misuse, as well as evidence-based prevention and treatment programs to address these problems. Today's webinar will describe the prevalence and impact of these issues in older adults and will identify screening strategies and evidence-based treatments, and also actions that state and local agencies can use to implement effective treatments with a specific focus on a strategy that one area agency on aging has used in implementing healthy ideas and pearls. Other webinars that specifically target the aging network for the series will include prescription medication and alcohol abuse webinar, which will be in May, webinar on reaching and engaging older adults in September, one sustainability and financing of behavioral health interventions was scheduled for October of this year, and one on family caregivers as clients and partners in care was scheduled for November. And be on the lookout for notices about registration for those webinars. The next webinar, as I mentioned, will focus on prescription medication misuse and abuse. It will be on May 16th, 2:30 to 4 o'clock. All who are registered for this webinar will receive upcoming webinar registration information. I'd like to thank you for joining us. I will turn things back over to Jennifer to introduce the presenters and sections for this webinar. Jennifer?
Yes, thank you. This webinar is broken into 3 sections. Dr. Steve Bartels from the Dartmouth Medical School will provide an overview of the prevalence, impact, and best practices for depression, anxiety, and suicide prevention in older adults. Dr. Nancy Wilson, Baylor College of Medicine, will provide examples of state actions to support the implementation of behavioral health interventions for older adults, and Ms. Cheryl Evans Pryor from Aging Resources of Central Iowa will provide examples of how an area agency on aging has implemented the Health Ideas and Pearls program for adults with depression. There will be 15 to 30 minutes at the end of the webinar for questions. Questions must be typed into the comment box. The webinar will be recorded. Slides will be provided to all who registered after the
Well, she dialed into the audio on the phone.
I would now to introduce Dr. Steve Bartels, our first speaker. Dr. Bartels is the co-scientific director on the Technical Assistance Center. Dr. Bartels is a leading expert on mental health in older adults with more than 30 years' experience in both behavioral health and primary care. He was co-director on the first Technical Assistance Center for Older Adults and provided TA Center from 2008 to 2011 cohort of SAMHSA Older and TCE Grantees. Dr. Bartels is a professor of psychiatry and community and family medicine at Dartmouth Medical School, as well as a professor of health policy at the Dartmouth Institute of Health Policy and Clinical Practice. As a leader in the field of mental health and aging, Dr. Bartels has extensive experience directly supporting major research organizations and associations. Since 2007, Dr. Bartels has served as the director of Dartmouth Center for Health and Aging, where he leads the Dartmouth Center for Aging Research, the Northern England Geriatric Education Center, and Dartmouth Hitchcock Aging Resource Center. He has received many honors for his work and service, which includes a term as the president of the American Association of Geriatric Psychiatry and the founding chair of the Geriatric Mental Health Foundation. Steve? Dr.
Great. Thank you very much for that very kind introduction. And I'm really excited to be with all of you today to go over this topic and to have my colleagues who will be following up on the practical implementation. Without further ado, what I would like to be doing is provide a bit of an overview before turning it over again for some more lessons around the implementation at the state and local level. If we could have a slide, please. So this is what you know. You know for sure about the baby boomer, the called tsunami, silver tsunami that we're looking at. And this is, I think, something we're all familiar with, and all of us, when we give our talks, attribute the focus on older adults to this significant tsunami. So next slide. What you do not know is that if you look at the projected prevalence of major psychiatric disorders by age group, those who are over age 65 will more exceed those other groups that you can see in this table here by the year 2030. The take home here is that when you're talking to local agencies, particularly those that are mental health agencies, not necessarily agencies on aging who get this, but the local primary care and mental health providers, that this demographic imperative is going to substantially shift the way we think about providing mental health services, so that all of us are going to need to be capable in that specific group of people who are age 65 and older. Next slide. Look at the prevalence of late life disorders, in specific depression and anxiety disorders. What we see in this slide here is that it varies substantially, particularly with respect to depression, in where you look. And so, though the general prevalence in community for depressive symptoms is around 15%, or major depression, as the symptom of depression is 1 to 3%, you can see that if you start moving into primary care or mental inpatient, hospital stays, or nursing homes, that the rates dramatically skyrocket. So take home here is that if you are working with providers, particularly primary care providers or long-term care providers, that it's important to be able to know that the rates are as high as 1/4 of individuals in primary care, have clinically significant depressive symptoms. So 1 in 4, and 40% within nursing homes. So that's really quite prevalent if you look at treatment prevalence, where the things where people seek health care. Anxiety disorders, we're not so sure about the distribution in different settings, but suffice it to say that depending on how you define anxiety disorders, rates can be as high as 12% in people over age 65. And it's very important to recognize that, particularly in older adults, that anxiety and depression frequently commingle. So it's not uncommon at all to see mixed symptoms of both depression and anxiety together in older adults. Next slide. Risk factors for late life depression and late life anxiety disorders. Well, here you can imagine medical illness and individuals who have significant medical comorbidity in which on multiple medications is a major risk factor for late life depression. Now, of interest, people who report poor health and disability in the context of multiple are more at risk. So I might imagine you might have two people who have equal amounts of medical illness, both may have cancer, and if one individual feels that they are in fact more disabled, or more pain, or they're more negative about their condition, and feel that they're not socially not supported, more likely to be depressed, even next to that person who has the same exact medical disorder. So having comorbid medical disorder by itself is not sufficient, but particularly having complications, having poor social support, if you're bereaved, having been recently widowed, obviously, having also more the burdens of aging that may occur sometimes are associated with depression. Although you'd know that actually if you look at the overall rate of major depression, actually is less in terms of prevalence in older adults than younger adults. So the stereotype that as you get older, it's going to be depressed simply isn't true. It's actually the case that the prevalence of major depression actually is less in older adults than younger adults, in part recognizing the resilience of older adults. And it also underscores this idea that depression is not normal, is not a normal part of aging. Anxiety, as you can see here, there are a number of different things that can produce anxiety disorders. Certain medical conditions, people particularly with cardiac conditions, arrhythmias, or people with breathing disorders, individuals with congestive pulmonary disease who have not much capacity or have limited ability to oxygenate and feel short of breath all the time. Anxiety very high in this group. Individuals who have stressful life events or being widowed or separated, individuals who had physical patients, and anxiety throughout life. Often individuals who have been anxious throughout their life, sometimes as they get older and support strip away, are more likely to have reemergence of significant anxiety symptoms in late life. Next slide. What to know is that mental illnesses, regardless of age, are the biggest cause of disability. And so that I don't think I'm sure it's preaching to the choir here that the consequences of psychiatric and mental health symptoms in older adults are profound. There's extensive literature on the fact that people after heart attacks are more likely to die if they're depressed, or people with cancer are more likely also to have mortality. A host of data on the intermingling of mental health and physical health in older adults. Suffice it to say, this is a major medical burden across all disorders, exceeding all others. Next slide. Certainly one of the burdens is poor functioning disability, or one of the poor outcomes of depression, but another is obviously suicide. And I'm sure you know that the highest rate of suicide of any age group are people age 65, and individuals 85 and older have a suicide rate which is 2 times the national average. And what we know is that the greatest risk is among Caucasian males, older men, particularly those who are widowed, divorced, separated, and who engage in substance use disorders, who are cognitively impaired particularly. If you look at research that's been done trying to reconstruct suicide after the fact, what's really remarkable here is that individuals who complete suicide, particularly older men who have successfully completed suicide, 7% saw their primary care doctor on the month of suicide, 40% on the week of suicide, and 20% on the day of suicide. What this means is that individuals who are particularly older men are coming into primary care physicians' offices in distress. It doesn't mean that they're saying, I want to kill myself and I'm feeling like I want to end my life. Quite the contrary. When I looked at these suicides, usually these are non-specific but significant distress, and this underscores the need to train primary care providers and other individuals who regularly touch the lives of older adults in routine screening. Next slide. Here again, this demographic of the suicide, the different rates of suicide, and the way that they particularly climb, especially for white males, but also go up black males. Interestingly, older women seem to be more protected around middle-aged years in terms of suicide. Next slide. Risk factors. Well, the risk factors include obviously having depression, major depression, but in the syndrome of depression, the thing to look for is hopelessness. Most of the studies that have looked at individuals who commit serious suicide attempts, it's not just that they have depression, namely low mood or difficulty with energy or some of the difficulties with sleep, but that depression is marked by a sense of complete despair and hopelessness. And if you compare that with suicide attempts and individuals who are in chronic pain or are socially isolated, you really start to pile up the risk factors substantially. And we also know that access to lethal means, particularly guns in men, dramatically increases suicide rate among older adults. What this slide shows you here is that in older adults compared to young adults, there are many fewer attempts for every completed suicide. In contrast to the general population, we could have 35 attempts for every completed in older, there are 6 attempts for every 1 death, and 4 insurance visits for every 1 death. So you can see that individuals who are older who make attempts are much more likely to succeed. Perhaps that's due to the fact that individuals who are older are more vulnerable, more frail, more isolated, less likely to be rescued. They're more likely to be planful and determined. And again, particularly for men, they're more likely to use firearms, which is a more lethal means than overdose in most instances. Slide. So, first, we should be thinking carefully about how to systematically screen individuals. And part of this initiative that we're talking about promoting through SAMHSA and through the Administration on Aging is thinking more broadly about where we should be doing screening. So you can see here that although most screening in the past is focused on mental health services, it really tends to think much more broadly, thinking about where people older seek and receive a variety of services or seek help. Social services, clearly, thinking about senior centers or transportation services or peer support services that might be touching individuals who are despairing and on the brink of suicide or being depressed or significantly anxious. Think the array of community providers that can be so-called gatekeepers, which we'll talk about in a few minutes. Identifying people at risk. Primary care, I think we've underscored already, very important. Very older adults are to walk into a specialty mental health center saying, I'm suicidal and I want mental health care. Much more likely to walk into a primary care office and say, feeling well, I don't have any energy, and I'm just feeling like giving up. Finally, many people seek some of the counseling or support services from faith-based sources. Another important place for us to be training and supporting individuals. Next slide. Training tools, and there are many, but we need to focus on several here. There is the PHQ-9. There is a component tool from the same initial instrument, which is called the PRIME-D. It's been derived for primary care. There's the General Anxiety Disorder 7 question instrument. Some people use the Geriatric Depression Scale, and then there's also some suicide questions that can be helpful, particularly suicide question, the PHQ-9, the 9th question, was an important and interesting and clear way of asking a very direct question. And there's a particular suicide screener. So we'll go over these in kind. But one of the major things I want to underscore is that there's absolutely no data that supports that asking an older person or anyone about thinking about suicide will put the in their head and will promote suicide. So support. And so in screening, you will know thoughts you may potentially save a life. Next slide. One of the major instruments we frequently suggest people be familiar with is the PHQ-9, which is showed here. And the reason why this has been promoted is not necessarily that it's geriatric specific, but it's a brief and easy-to-use instrument that primary care physicians in particularly understand, and it's been promoted in primary care. In fact, the PHQ-9, many of us who have been promoting this nationally talk about it as the hemoglobin A1C of depression, basically the diabetes measure. You know, it's as simple as doing get blood, as simple for diabetes. It's just as simple as doing this sort of screen. So what we'll do is we suggest to primary care physicians that they ask the first 2 questions here. You had little interest or pleasure in doing things. Have you been feeling down, depressed, or hopeless? That's the PHQ-2. And if anybody answers positively to either of those 2 questions, then we suggest to primary care physicians that they complete both PHQ-9 for the whole thing. So it's a stratified approach. You'll notice the last question on this, I at the bottom, is the suicide question. You see a very compact way this instrument can help screen. Actually, it all helps track. There's a way of coding this that helps differentiate major depression versus minor depression, which I won't go into, but it's quite useful. The Geriatric Depression Scale is also, I think, quite useful. It doesn't have the same suicide question and used as much in primary care, but is a good alternative. Next slide. In terms of screening for depression, this is the sister of the PH9. It's the anxiety set of questions. You can see they're rated exactly the same way in terms of the frequency, not at all, several days, more than half of nearly every day, and as a way of quantifying the presence of general anxiety disorder in older adults. We don't necessarily recommend that this be used in every instance in a contact with an older adult. If we choose and you don't have much time, clearly screening for depression is really of great importance. And again, 2 questions I mentioned, minimum to start is the place to go. If you have someone who has mixed anxiety questions, this is a good screen. Next slide. So what happens if you find that somebody positively that they have some thoughts about suicide? It suggests that if anyone has a positive response, that what you want to do is you want to look at defining whether or not the individual actually has specific ideas of wanting to hurt or kill themselves. Not uncommon for older adults to have passive suicidal ideation. A mother used to say, "Steve, I'm ready for the boneyard. I could be dead tomorrow and I'd be fine. I've had a good life." Well, that's ideation, and is very normal. And then there are people who sometimes say, "I think sometimes about ending my life, but I'd never do it." It's important to ask those questions to specify. Are you specifically having thoughts of hurting or killing yourself, not passively dying? And then if you go to the next slide, there is an additional screener that's sometimes used in high volume settings where people are seeing many individuals with suicide risk. That actually goes through a number of 4 specific questions that you can see bring you down kind of a decision path to rank individuals as being minimal, low, or high in terms of suicide risk. And so you see if somebody's, number 3, big difference between a thought of acting versus you doing it. And if someone is likely, very likely, that's a great concern. Next slide. So what are some evidence-based interventions that exist? In addition to needing to screen, we need to be able to do something about the screen. And so there are outreach programs that exist in terms of helping to identify people in the community who are at risk for depression or anxiety or substance use disorders. One is a very interesting program, the PATCH program in inner city Baltimore, had trained Indigenous workers, managers, and janitors through using what's called the gatekeeper model, training people who live in the community to identify older individuals' risk, and then referring to a psychiatric nurse and doing an evaluation, even beginning treatment in the individual's home or apartment. And that was effective in reducing psychiatric symptoms as a great example of an outreach program in a lower-income, indigent inner-city population. Next slide. Common and widely spread models now that I'm sure you've probably heard about is the impact model. And this specifically for identifying, screening, and treating individuals through brief interventions in primary health care settings. This, which has also been called collaborative care, a care manager, a depression clinical specialist. This could be a nurse, a social worker, a health worker who provides patient education, who is screening with the PHQ-9, and tracks that over time, and is trained in delivering brief problem therapy, which is developed for primary care, so-called PST-PC. And it's also coupled with primary care physician consultation and involved teams to cover if necessary. Individuals are given either medication or problem-solving therapy and then monitored on a very regular basis. And if getting better, then again, treatment is changed. Next slide. This is the depression care components, which are in any kind of algorithmically driven model, which is adapted in the community outside of primary care also. And you'll see it's all about screening, helping people in self-management, manage monitoring people over time with an instrument, giving a brief intervention, and coupling that with medication treatment and doing stepped care. Next slide. The study that looked at this looked at individuals who had depression care management versus care as usual. You can see that over time, those individuals who had depression care management did a lot better and were much more likely to recover in terms of their depression compared to usual care. Next slide. That now the whole idea of this collaborative model of screening and monitoring and delivering brief interventions has been also offered within community settings. And Pearl's model is an example of a community-integrated home-based depression treatment, which looks like the IMPACT model in many respects, except it's done in the patient's home or the client's home. 8 sessions, 40 minutes to 6 minutes each. After you screen the person originally and identify them as having depression, delivering problem-solving therapy, social activation, and pleasurable activity scheduling, and using a team approach. And if you look next slide, what you see is that the results here are as competitive with the IMPACT program. Here you'll see 50% reduction in depression in the Pearl's model compared to usual care. It's very important to note that there are, again, these components of stepped care and using a manualized intervention such as problem-solving therapy is the key, and screening people downstream to make sure they're getting better. Simply doing supportive psychotherapy or general counseling is not good enough. You need to be following these algorithmically driven, clearly oriented therapies, or to use so-called activation strategies and monitor people over time. Next slide. The idea is you'll hear a little bit more about later, is another evidence-based practice, which again is focused on community-based interventions. It's embedded in case management programs and conducted in a client's home on a one-to-one basis over 3 to 6 months. And this has similar components here. Screening is essential around depression and assessing severity. Education also provides referral linkage to health providers, which is a little different in the sense that if people need pharmacological treatment, that is provided outside or specialized care. But it has also a component that's similar to, again, one of the components in problem-solving therapy, which is behavioral activation, empowering people to manage their symptoms, to engage in specific activities that are pleasurable or meaningful, and taking one step at a time towards being more active and less passively depressed. Next slide. So we've put together worked with SAMHSA in helping to put together a treatment of depression toolkit. In essence, this is an implementation evidence-based practice kit that you can obtain on the web. It is free. Your tax is paid for this. And this particular evidence-based practice kit helps you to select the specific evidence-based practice for depression in your agency or in your particular clinical setting. So it'll walk you through what are the different aspects of the different evidence-based practices, what competencies and capacities that you need to implement the evidence-based practice, and where you can learn about getting in it and implementing it if you need it. So I'd really recommend this recently released, a very nice product SAMHSA has put together that a number of us contributed to over time. That's available to you. Next slide. Anxiety, the important thing here is that you may start seeing that there are similarities. So one of the major effective treatments for anxiety is, in fact, really oriented psychotherapy. So cognitive behavioral therapy, supportive therapy, and to some extent also problem-solving therapy is effective in anxiety. And then also pharmacotherapy, usually consisting of antidepressant medications, not long-term treatment with benzodiazepines, which is not indicated. And then providing certain supportive service delivery models. And once again, these should be protocol-driven. But the good news here is that often many of the things that work for depression also work for anxiety disorders. And when there's mixed anxiety and depression, cognitive therapy and sometimes SSRIs as an antidepressant medication can be helpful. Next slide. we think about prevention and early intervention, the optimal focus really to focus on both individuals who are at significant risk, that's indicated prevention. So those are people at increased risk, like those people who are depressed, and universal, help to train everybody in looking for and detecting and helping older adults who may be at risk in the greater population with respect to suicide prevention. Next slide. About these different areas, universal prevention is a population-based approach to prevention, and selective and indicated is focusing on people at more risk. You can see in this table kind of the summary of what I've been talking about here. The universal prevention strategy is to implement screening in places where people seek and receive care, and it should be at a minimum using the PHQ-2 to start those 2 questions, and then maybe expanding to a larger array of questions if necessary, and then doing suicide risk screening. Harm threat reduction, really important. We know that particularly the highest rate of suicide is among older men, and the major means is firearms, so that's a really important target in terms of thinking about reduction. So alcohol and medication misuse dramatically places people at increased risk. And then think about a multi-layered suicide prevention with workshops, depression screening in neighborhoods and senior centers and long-term care, and referral for treatment and consultation when necessary. When we have actual specific risk factors like depression or a significant risk, then what we want to do is think about identifying those individuals through outreach, such as the Gatekeeper Program or PATCH, from telecheck or telehealth in terms of support, and then, as you've heard, PEARLS, problem-solving therapy, PST, IMPACT, or Healthy, as a number of these interventions are all useful in terms of thinking about risk. Next slide. Make you aware of the National Suicide Prevention Resource Center that is available, that is really federally funded and has a number of excellent resources. You should visit the website. It's not only various tools that can use around best practices and a primary care toolkit and training institutes, but also there are capacity to help answer your questions as they come up around various concerns that you might have or programs you're thinking about. Next slide. Here, too, you can see on the web page various aspects of what they make available to you: evidence-based programs, consensus statements, standards, materials, and a number of things that are available to you that you should take advantage of. There's also this specific toolkit that's been developed that you can see here on promoting mental health and prevention of suicide for senior living communities, which I would commend to you. It's very useful, very easy to read, and an educational resource that you could share with some of your colleagues within senior living communities. Next slide. The National Suicide Prevention Lifeline, there is a particular phone number that you can hand out to individuals who you are serving or their family members. They will provide crisis management 24 hours a day and provide assistance in getting help when that comes up. Next slide. So, kind of in summary around the suicide assessment, there are the focus is on identifying risk factors, thinking about protective factors, conducting an inquiry around thoughts, plans, and behaviors, determining the level of risk, how acute the risk is, choosing a specific intervention to address the severity of risk. And again, you can find this as part of one of the tools at the suicide prevention site, and is available as shown here. Next slide. A quick tour as an overview, and hopefully gives you an orientation to the issues with respect to depression and anxiety, and prevention in terms of prevalence and risk factors and strategies. After having done that broad swath in terms of an overview, what we want to do is drill down into specific examples for the state level and then subsequently at specific service provider level. So it's my pleasure to introduce to you to provide some examples of support for evidence-based practices for depression care management with respect to states is Nancy Wilson. Nancy Wilson is a social worker who is specialized in gerontology and is well known as a national expert in geriatrics, and particularly social work and geriatrics. She's associate professor in the Department of Medicine of Geriatrics and assistant director of the Huffington Center on Aging at Baylor. She's an associate of the Baylor VA Houston Center for Health Services Research, a very active researcher, particularly focusing on healthy ideas and a number of other areas that she's championed over the years, and works from the Texas Consortium of Geriatric Education Centers. At Baylor, she's largely been devoted to developing and overseeing interdisciplinary education and community training programs in aging and creating community-based research in community long-term care and mental health. And most recently has been the leader of an interdisciplinary academic team and spearheaded the development of healthy ideas. So it's my pleasure to introduce to the next segment to you a friend and colleague, Nancy Wilson. Nancy?
Thanks, Steve. I am happy to follow you and also energized around the challenges that we all face. I think that we can all appreciate that community agencies, as was indicated, reach at-risk populations and have very vital roles to play in addressing the disabling conditions of depression, depressive symptoms, anxiety, and obviously in addressing suicide risk reduction. And as we've heard, we have evidence-based practices and some models and have very exciting and valuable toolkits to support our efforts to advance attention to these concerns. However, I'm sure you're all thinking, as we often do in our field, one more thing that I need to think about how I can do in this time of limited resources. And we certainly do face challenges in modifying practices and implementing new program models that take new partnerships. I'm going to spend a little bit of time talking about some of the outstanding leadership that I've seen in states around the country that are stepping up to these challenges and figuring out how to work together. And I think those of us in aging services have been implementing evidence-based programs around a number of conditions and challenges that require partnerships. We always have to start with thinking about what our resources are, who needs to be on the team, what it is we feel prepared to do in our community and our specific agency, and how do we meld the professional resources needed for that, and then obviously how do we track what we're doing. As was emphasized by Dr. Bartels, we don't want to just begin asking questions and not take action and follow up to see benefits. So next slide, please. I'd like to talk a little bit about key challenges I think we face that are a little bit more unique than when we're perhaps addressing an issue that has been within the scope of either mental health services or within aging services, and that is we all share the same coffee pot or water cooler in the case of Texas, and we don't have an instant app for how we build these partnerships and how we think about what we're able to tackle and where what we're able to do in terms of introducing attention to these issues. And we know from work that's been done, and it'll be clearly described in the toolkit, which I encourage you to download on evidence-based practices discussion, there are key steps we know to be able to be successful in implementing evidence-based approaches that involve thinking about what skill set we have and how do we meld the clinical behavioral health expertise to support our frontline aging services staff, many of whom may not have had extensive training in addressing behavioral health issues or even having these conversations, being able to apply standardized screening tools may be a new change in skill set. So we have to think about how we incorporate these actions into our day-to-day work and how we build the relationships we need. And this is where I think states have very vital roles. Next slide, please. I want to talk a little bit about how states have helped agencies have the right leadership and help them identify the necessary coaching and training expertise. All of us who are involved in day-to-day delivery learn in the doing. So once we learn a model, we have to be able to get support in implementing it with clients. how do we set up these linkages and referral systems? Because again, depression is a condition, and anxiety, oftentimes we need further evaluation and attention. As was talked about, we may need attention from pharmacotherapy. How do we have these systems in place? Because again, we're often working across silos of financing and delivery. So what have states done to support this sort of implementation activity that's essential, even if we're just going to start paying attention to screening and suicide risk reduction or community education? We want to think about what are those systems in place to respond, because as was said, screening itself is not sufficient. We need to think about what supports are in place. So next slide, please. So to say that webinars like this and the type of partnership that I think that SAMHSA and AOA are illustrating to us by convening us all together is something that can be replicated and emulated at the state level. And by that I mean states have very vital roles to play in exposing their key stakeholders to evidence-based practices and approaches. How do we translate the information we've heard today to agency levels to help them think about how to take action? Hearing information from peers, as I've learned with adolescents, is oftentimes the most valuable way to influence practice and behavior. Let them hear, as you're going to hear shortly, how an agency in their state has taken action towards implementing either, if not a full-blown depression care management model, has begun to pay attention to depression or anxiety in other approaches. And so thinking about what are those forums where the states can take valuable time and say, along with talking about falls, let's about how we can address depression and suicide. One of the vital things we have going for us now are oftentimes technology platforms such as webinars and teleconferencing systems that allow us, although we may be at different addresses in the same community, be on the same phone call. And states have done very exciting things to bring together expertise from mental health and aging to support agencies as they do things like develop suicide risk protocols or think about how they're going to learn or continue to use their skills around a model that they may have been trained in. So that's another vital opportunity to support this kind of careful work that we need to do to modify our practices. Next slide, please. So oftentimes these partnerships may come from a local agency approaching a state partner to say, can you help facilitate access to the suicide support training that's available through mental health? But many times states themselves have exercised this leadership, and I want to commend to you just a few that I've seen where mental health and aging at the state level, not full-time dedicated people, pieces of individuals have come together and said, how can we bring our resources together to advance training and practice? In Ohio, they've made major progress across the single state agency for substance abuse as well as mental health as well as aging to consolidate resources and do a lot of joint training, including giving mini grants to area agencies on aging that adopted healthy ideas and other gatekeeper approaches that you've heard about. Training workforce is obviously a key issue. How can we do that jointly across agencies? And again, you have geriatric education centers or HRSA-supported training going on in state institutions. North Carolina has used this. The state of Oklahoma was able to mobilize through the Oklahoma Department of Mental Health their aging expertise to reach out to several agencies that were going to be implementing a depression management model. So there's lots of opportunities to do this. And obviously, through all our work that's going on with the Aging Disability Resource Centers, we know that there's also a lot that the Aging Services System can trade off in supporting what's going on with behavioral health delivery to older adults who need assistance. I think a key area where I think there's great hope is also the crisis team suicide hotline linkage, making sure that we know as Aging Services begins to address these issues, how they can be supported in this key issue. Next slide, please. So key opportunity where states can do things that may not be that may at least be cost neutral is to look at our mandated tools that we're requiring for service providers to use and use some of these tools that we've heard about today to begin to look at the prevalence and to help individuals take action, but also help communities know the scope of the problem around depression, around alcohol use, around suicide, so we know how to direct resources. So many agencies, most recently I've seen a version of the state of Florida, have totally refined what they're doing, and this is valuable use of state policy expertise. Likewise, I think we're all always eager to make sure that we maximize all funding sources and how those can flow across silos. So do we have opportunities for within Medicaid, within state finance programs, to even using pieces of those funding to address these sorts of issues? And we've heard recently about new opportunities for Title III. Again, perhaps we can support coaching expertise if we're not always to support all of the frontline, adding frontline staff. And then we've agencies that have allowed their community mental health centers to redirect resources that have been previously used to just work with individual clients to be the coaching support to an agency staff that's trying to adopt some of these evidence-based approaches, cognitive behavioral therapy or cognitive behavioral strategies, having that coaching support. Next slide, please. So other opportunities that I think we're all excited about that states have begun to think is, how do we work within our existing Medicaid framework, realizing that, again, depression, anxiety, these are substance misuse and abuse, these are key disabling conditions that we see in our population of older adults receiving long-term care, particularly community long-term care services. I commend you looking at a webinar that talks about how the state of Washington has been able to modify its 1915C waiver because they had valid data from using valid depression screening tool in their program to look at a gap in service to persons with minor depressive disorders, and have now been able to incorporate that into their 1915C waiver. An upcoming publication will talk in more detail, but there's also more resources available to talk about a pilot going on in the state of Texas, and there are other pilots going on in this area as well. Through Money Follows the Person, how do we address the population of older adults who may be able to live safe and independently in the community if their behavioral health needs are addressed, including substance misuse as well as depression treatment. So these are programs to look into, and other avenues to think about how do we use our state policy, financing, leadership, and options within Medicaid systems. Next slide, please. I also highlight the fact that oftentimes to identify the scope of the problem, we could benefit from working with individuals whose attention is often on looking at issues around data, which may be academic institutions or it may be state evaluation teams, helping agencies look at whether or not again, to deliver services, you're seeing improvements in rates of depressive symptoms or anxiety, but also helping to figure out what the scope of the problem is to help make the case with funders, whether that's public funders or private funders. So think about making those requests if you're at the local level, or think at the state level about how you can offer that expertise. Next slide, please. Likewise, we oftentimes know that within many of these programs we need to offer education, which is not always done by verbally doing things, but have manuals, having materials available that are consumer ready to be used. That's something that many states have said, we can't fund personnel, but we have a printing budget that we can support you around this area. We know that there's been very exciting work going on around other chronic health issues where we can get attention to depression, incorporate attention to comorbid conditions such as those that Dr. Bartels talked about. I've personally seen diabetes initiatives where, along with focusing on healthy behaviors related to diabetes, we were able to get attention to depression considerations. And then again, there's been very exciting work going on with chronic disease self-management delivery through peer mental health specialists. Perhaps there are opportunities for peer training around other mental health models. Slide, please. I'm very privileged to introduce to you now a local champion who I think exemplifies the best in leadership in advancing evidence-based practice, Cheryl Evans Pryor. Cheryl is a gerontologist with over 25 years working in the field of aging and mental health. She is a very dedicated project manager for evidence-based practice programs within the state of Iowa, specifically the AAA known as the Aging Resources of Central Iowa. I'm very proud to say she's a certified regional trainer in the Healthy Ideas model and has trained not only in her state but in a neighboring state, and is also a local trainer for the Pearls model. She's been responsible for leading the training and implementation of both Healthy Ideas and Pearls within her AAA region, and has focused very carefully around issues of adopting and implementing a program pilot to help look at what can be done to take things to scale. So Cheryl, please tell us how it works at the local level.
Thank you. What I'd like to offer you today, I'm here with my esteemed colleagues who have helped bring these evidence-based practices to fruition here in the state of Iowa. I'd like to offer some practice-based evidence that these program models do work, and from a practitioner perspective in regards to the implementation of the models. The mission of our AAA, or Area Agency on Aging, is to advocate and provide service coordination through both federal, state, and local support to persons 60 and older. We want to encourage individual choices and help folks remain safe and independent in the community. That's our primary mission. And we've done so by taking a proactive role regarding mental health services and working with collaborative partners to address the behavioral, emotional, and psychological issues that older adults do in fact face. And my role is to provide consultation with the partners regarding the barriers and the implementation issues, also regarding outcomes, and then of course training and coordination of these models within our areas. An additional role I have here at the agency is I do consultation with our case management staff who are implementing the Healthy Ideas. So that has, for a co-location model, that has worked very well for us also. Regarding implementation of, the next slide please, Healthy Ideas. We started our training for Healthy Ideas, and we were very fortunate to have Nancy Wilson be the national trainer to train us in 2010. And we also have a clinical consultant, as well as the case management team and team leaders in our group, and complete our pilot project in February of 2011. Management staff provide the in-home services and coordination of service to clients in their home or an assisted living facility. They do not coordinate services if that person then goes to long-term care. So in working with our local mental health center, and who is our partner and our clinical consultant, our team, we have an agreement on a fee-for-service arrangement, an agreement for updated training that we go through. Since most management clients are frail and homebound, one of the strategies that we implemented is deciding to do the initial screening for Healthy Ideas at the 90-day visit instead of at the initial visit, and that allows the case managers to not only build a rapport with the older adult, but also to complete their service paperwork and implement and institute the brokerage services that they need for the older adult. And so we chose to take that 90-day approach, which has worked well for us. To date, for the ideas, we have screened on a positive score of 6 or more on the geriatric depression scale, 101 clients, and 52 of those folks have successfully completed the program. We first are self-identified through enrollment, assessment, and screening. So we meet the folks where they currently are and their identified needs, even though they may have a history of depression, but we meet them where they currently are screening in at through those instruments that we use. In the Pearls model, we adopted that model in 2009. We had to train our partners, which is senior outreach counseling staff through the local community mental health center. And the team leader also decided to get trained specifically from the folks at the University of Washington Promotion Research Center. So this person then would also be able to co-train with myself and in-house train the other staff in interdisciplinary team that they have at the mental health center. In 2010, then they started to conduct screenings for both clients that were new and referred clients, and their program serves folks that are 60 and older. An in-home counseling service, which is unique in that they are able to go to where the person resides and conduct that counseling. So an outreach service through the mental health center, it works very well. And psychiatric consultation then is provided by their psychiatrist at the mental health center, and that certainly helps with the fidelity to that particular model. And they have consultation every month, case consultation. A host of providers in the community and get referrals from as well, not only the area agencies, but for-profit case managers, home health agencies, etc., and also work with various public service providers. Please. The major cases that they serve with mood disorders have major depression or major depressive disorders, which does preclude them from meeting the criteria for inclusion in the PEARLS model, as that model is for minor depression and dysthymia. It is voluntary participation in the model, and it is 8 sessions over a course of 19 weeks. They have screened and enrolled to date 25 clients, and 10 of those folks have completed that program. The integration of the screening process, and the screening can be quite lengthy in their admissions process, so they've synthesized that information to make it easier to identify those symptoms of minor depression and dysthymia up front. And then algorithmically they can decide which way to proceed. The trained clinical consultant provides and motivational interviewing skills to staff, which are necessary, and it helps increase benefits of feeling better and problem solving. Next, please. The outcomes of the PEARLS model, there has been significant symptom reduction, improvement in their PHQ-9 scores, to specialists such as neurology or psychiatry. The problem skill set that they acquire can be used universally, and also it helps them build their sense of confidence, which can be a major barrier for folks in dealing with depression, and helps their coping skills, and folks do gain a significant amount of insight into the connection between their mood and behavior. In events, they request assistance from their family and are more likely to ask to go out and do things together and participate in outings. And that is one of the key components to that model, is experiencing more pleasant events in their life. Next, please. Regarding outcomes for the Healthy Ideas model, we have 101 clients have scored a 6 or more, which is a positive score on the geriatric depression scale. 52 of those clients have successfully completed the program. And in addition to the score reduction, we've had increased activities at home. People are experiencing old hobbies or experiencing new things, new interests that they might want to try. Talk about their pain levels have decreased. They have gained some confidence in their ability to cope with depression and report that they, in general, just feel better after having participated in the program. when we the elements of implementation and how it has been successful, for both of these models, it's very important that I think the number one thing that's been successful for us is we've established these collaborative relationships. Instead of focusing on our own sources of expertise, we've really all come to the table and willing to be collaborative partners, and that's been one of the things that's very exciting about these models, is working with colleagues in a different capacity. It has taken leadership and having a good understanding of that it works and that it's essential to embed these programs into your existing programs that you serve with older adults. Having a systematic approach and embedding it into your practice. These are time sensitive, they're short-term interventions, and they're cost-effective. It's more in line with the brief treatment model that is very commonly utilized in the mental health world. There's also understanding, of course, that not all clients want to discuss their emotional issues or trust someone to do that with, and they may have, for other reasons as well, it might just be that they don't have the energy, or they might not have the buy-in that this person can help them emotionally. They may be skeptical. They may in fact sabotage your efforts, and they may sabotage their own efforts. We also want to help those who are willing to participate. So the folks that want to participate, we're going to proceed forward and help them as much as possible. Next slide, please. We have challenges to overcome in both models as well. First of all, embracing the readiness to change, which can be quite scary for folks, and it's another new process when people have limited time, especially case management staff and clinicians in the field see numerous clients in a day, so embracing that readiness to change ourselves was one of the biggest first steps that we had to accomplish. There was some initial resistance to change, and certainly the time elements that are involved in the training and service delivery. In funding, we had to make sure that we were able to secure adequate funding, and there may be different streams of funding for various parts of the training and or the documentation pieces, and figuring all of those out and trying to streamline the process, use consistent forms, and trying to reduce the variability to make it easier in a systematic approach for everyone to operate in the same way. And initially, we utilized braided funding to be flexible. We felt we had to be flexible in order to make it all work. Next, please. That we have some essential leadership, and we've been fortunate that with our executive director and board of directors, as a management staff here, that they have a global understanding of how we have the unmet needs of older adults regarding mental health, that we want to take a proactive role in making sure that we address those issues and serve them in the best capacity possible. Some partners may have decided that their contributions, they're going to find their own contributions and set boundaries around what they're able to do and not able to do. And taking a more global picture of what would it look like if we had optimal mental health services, and what would that look like for the older adults in the community, and keeping those things in the forefront of our mind as we move forward. We have been very committed to being solution-focused and not allowing these barriers to get in our way. And the sense of accomplishment that both the case management staff, the clinicians that are providing the service in the field, those types of accomplishments propel us forward. We have to learn that we have to accept that stakeholders might become change agents or early adopters despite our encouragement, and have a realistic recognition of the barriers to implement the models, also just the barriers for depression care services in general. We also have become risk takers and creative in addressing our program needs. We want to make sure that we have a consistent message, that we're all in it together, and that the problem is much bigger than all of us, and also recognizing that we are, in fact, helping deter suicides. For the fact that we have to stay on course with this and provide better services overall regarding mental health, and being proactive in our action and establishing leadership. So celebrating successes that the clients have and the staff have. In the slide, please. We talk about braided funding. Part of my role, I'm funded through a Geriatric Education Center HRSA grant at the University of Iowa, and additional grants. Our The Ideas model is sustained through state elderly waiver funds. It's Medicaid dollars. Referrals model is the assessments. Again, it's that braided piece. For county funding, they have a contracted rate, and then also for the sessions that the clinicians perform, they have the elderly waiver or county funding to utilize. Next, please. So the importance and the value of these programs, I think for twofold. One is the older adults. We talk about engagement, and it's the self-permission can make change, which is really important. For the adults, one of the sense of value is for hope for improvement. We are messengers of hope and confidence building, which is very important for them to maintain their independence. And they get secondary appreciation. They learn a new skill and acquire a new skill. So problem solving and behavioral activation has been very helpful. It's task-oriented, so it's broken down in a stepped approach, and it stops folks from being so overwhelmed that they can't make any moves forward. And it's motivational, so it also helps them stop their procrastination. Next, please. Teaches clients how to ask primary care physician or specialist for assistance in identifying symptoms. And that's one of the greatest caveats, I think, of these programs, is that when you can have a client who is able to ask for help and articulate that themselves, they're then recognizing that connection between their mood and behavior and reaching out. When that occurs, then you're going to have better treatment compliance. It validates the older adult's values and concerns, and not necessarily the caregiver or the staff member. It encourages those natural relationships with their peers. Next, please. And finally, talk about the value and importance to families, as families report to the staff that they have improved communication and interactions, helps them recognize the contributions that the older adult can make, focusing on positive behavior and change versus negative, and it deters some of the codependency that exists, and it encourages progress, and you can set boundaries around it, and have the insight into dynamics of change and the stages of change, and how to resolve the ambivalence that occurs when we're in a stage of change. Getting some of those insight into those dynamics are very important. And at how to recognize the generational differences in a new context. It takes courage to talk out and show emotion, and some older adults are quite guarded about that. It can validate feelings, and allows families to be very supportive of the older adults who are participating in these models. So that's what we would like to offer you today from a practitioner perspective.
Well, thanks, everyone. This is Kathy Cameron with JS, and we don't have any questions that have been submitted, but I wondered if any of the speakers have questions of the other speakers, or SAMHSA or AOA. If you have some questions you'd like to pose, or those participants on the webinar, you still have time to submit questions if you want to in the chat box. So if someone would like to ask. Well, I think all incredibly comprehensive in your presentations with the overview of the problems and the evidence-based programs and the NC's review of state strategies for implementation and Cheryl's review what's happening with her organization in Iowa and implementing 2 excellent evidence-based programs. Okay, I have one question. Is there only private pay as a means for community-based services for social programming? So this question about financing of these evidence-based programs in community-based settings. Either Nancy or Cheryl, would you like to discuss that question and talk about different funding strategies available?
Oh, Cheryl, I'll start off, and please feel free to chime in. I don't know what setting the caller represents, but it's an observation that, and from talking to my colleagues who run the TA Center at Pearls, that a variety of different funding, public and private, particularly nonprofit sources have been used. So, for instance, close to home in my own community of Houston, we have social service providers who get support through their United Way service delivery, and the United Way here was particularly interested in the fact that they were looking carefully at outcomes and focusing on high risk. So these are agencies doing case management delivery that are also part of the Area Agency on Aging service delivery system. As was talked about in the state of Washington, their Area Agency on Aging case management providers have the option of getting reimbursed on a unit rate for delivering the Pearls intervention that Cheryl described. And we have seen that oftentimes getting the program developed initially is supported by foundations, which allows the agencies the opportunity to explore some of these other public sources. Want to add?
Well, as I spoke to earlier, that in our particular situation, we do use the type of braided funding, but primarily for our case managers is through the elderly waiver funds. And so that's how that is primarily paid for. Then the Pearls model is through dollars allocated for mental health interventions, as well as they can also utilize elderly waiver funds when they're seeing clients as well.
Okay, thank you. We have another question. How will mental health parity from Medicare impact Cheryl's most excellent programs in Iowa?
Well, I'm not sure how to answer that.
One of the things we recognize is that in order to get Medicare reimbursement, you have to be a certified medical provider, which typically requires a certain level of licensure at this stage, and we have found that it doesn't always require frontline providers of either Pearls or Healthy Ideas to be licensed providers if they have adequate training, support, consultative backup, and supervision. So one of the things I guess agencies will have the opportunity to look at is whether or not they want to have licensed behavioral staff. And we do have some community aging service providers around the country that already do bill for Medicare, but obviously we hope that the rate of reimbursement will increase substantially through parity.
Yeah, piggyback on that and say that as well, that the rate of reimbursement through Medicare currently for the community providers is substantially lower than other funding mechanisms. So in addition to having to operate the program in a certified Medicare facility and get that facility authorized, it also is an issue of the reimbursement rate being substantially low. So that will change.
Yeah. Thank you.
But I do want to underscore the Medicare wellness visit that many primary care settings are looking at. I think that these are important opportunities for avenues of discussion with community aging service providers to have with local health providers. How are they going to, if you're looking for depression, you have to have something in place. So maybe this is an opportunity for a partnership discussion.
Agreed.
Thank you both. A question came in about we'll get a copy of the PowerPoint presentations, and everyone who registered for this webinar will receive both a copy of the PowerPoint presentations as well as a recording of this webinar that you share with your colleagues in your organizations. Well, that's for questions. We want to thank all the presenters for your excellent presentations about depression, anxiety, and suicide prevention programs. And we will be sending out information about the next webinar, which will be in May, on psychoactive prescription drug misuse and abuse. So thank you all for being part of this webinar. Have a good afternoon.